Chapter 7 Pulmonary Edema. Topics: Pulmonary edema. Stages of pulmonary edema. Causes of pulmonary edema. Hypoxia caused by shunt. Shunt measurement. Case study number 7. George, 55 years old, stockbroker, well until 3 years ago. Central chest discomfort during exertion. Severe central chest pain on admission. Crushing pain which radiated to L shoulder. Very short of breath, coughed up frothy, clear fluid. 1 pack a day for 35 years. Further died at 60 of heart attack. Physical exam number 7, George. Anxious and sob. Coughed up pink frothy fluid. BP 110/65, pulse 100 bpm. No neck vein engorgement. Rails upon auscultation. No dependent edema. No edema. Investigations: ECG, recent L anterior wall infarct. Blotchy bilateral opacities in lungs. PO2 equals 59, PGO2 equals 35 mm of mercury, pH equals 7.35. Lung scan, radioactive albumin, absent blood flow. Pulmonary edema and me. Treatment: bed rest, morphine, diuretics and oxygen therapy. Pulmonary edema resolved quickly, 2 days, severe obstruction of LAD-CA, CAP performed. Pathophysiology: LV failure and pulmonary edema. Probably had CAD for several years. Pain on exertion was angina. The pain he felt on admission was from a myocardial infarction. When LV cannot function properly, pressure builds up in the LA and also the pulm veins. This increases pulm capillary pressure, causes stress failure and alveolar flooding. Pathophysiology: pulmonary edema. Capillary endothelium is permeable to water and some solutes. Alveolar epithelium much less permeable. Water actually travels in the other direction. Actively pumped from alveolus to interstitium, Na plus gate plus ATP pump. Hydrostatic forces move fluid out of capillary. Osmotic forces tend to oppose this. Physiology and pathophysiology of the lung. Starling equation. Q equals gate PC pi, sigma, pi C pi I. Q equals net flow out of the capillary. K equals filtration coefficient. PC equals cap hydrostatic pressure. Pi equals interstitial pressure. Pi C equals colloid osmotic press, cap. Pi I equals colloid osmotic press, interstitium. Physiology and pathophysiology of the lung. The values are not exactly known for most of the variables in the Starling EQ. However, net flow out of cap at arterial end, high up cap. Net inward flow and venular end, osmotic effect. Any excess outward fluid is collected in lymphatic vessels and returned to central circulation, empty into L subclavian V. Physiology and pathophysiology of the lung. Note that in normal circumstances, very little fluid buildup around either the vasculature or the bronchial tree. This increases in interstitial edema and reaches a critical stage in alveolar edema. 2 factors limit the outward flow of fluid from caps. Colloid osmotic pressure is higher in the vasculature, and gets greater as mostly water is leaking out of caps. Rise in hydrostatic pressure of interstitium as fluid passes out of caps. Interstitial and pulmonary edema. Interstitial edema. Engorgement of perivascular and peribronchial spaces, cuffing. Pulm function minimally affected. Alveolar edema. Fluid in alveoli. Alveoli shrink, due to surface tension. Ventilation is impaired. Hypoxemia, causes of pulmonary edema. Increased cap hydrostatic pressure. Recognized by measuring capillary wedge pressure, tilde pulm venous press. Increased cap permeability. Also incorporated cap hydrostatic pressure. Reduced lymph drainage. Heart failure exacerbates this as central venous pressure rises. Decreased interstitial pressure. Rare. Decreased colloid osmotic pressure. Uncertain etiology. Heroin overdose. Features of pulmonary edema: dyspnea, rapid, shallow breathing. Stim of J receptors. Orthopnea. Paroxysmal nocturnal dyspnea. Periodic breathing. Cough. Pink, frothy discharge. Rails, crackles. Rhonchi, musical sounds, severe edema. Septal lines, pulmonary function not normally done. Patients are pretty sick. Gas exchange. Impaired, particularly in alveolar edema. Shunt. Blood that bypasses the gas exchange portion of lung, normally accounts for tilde 5 mm of mercury ADIF. Shunt TQ. QTX CAU2 must equal Qs X CAVO2, shunt, and QTQs, X CAPO2. Rearranged as on Fig 7-6. End result. CAU2 is lower than optimal. Normally 1 to 2%, shunt to 100% does not correct hypoxemia due to shunt. Shunted blood never exposed to 100% O2. This is actually how best to measure shunt. This is why O2 concentration and PO2 are not raised very much by breathing 100% O2. Actually rise in CAU2 is 0.003 ml/dl/Hg PO2. So, 600 by 0.003 equals 1.8, so CAU2 rise is only a small amount. Due to the flatness of the upper portion of the O2 dissociation curve. Hypoxemia PO2 does not rise with shunt. Why? Chemoreceptors. J receptors, George. Hypoxemia, stim breathing. Low VA/Q also contributes to hypoxemia. Obstructed airways are not ventilated. Low cardiac output also contributes to hypoxemia. In George, the CHF. Mixed venous PO2 falls due to increased O2 extraction by tissues. Pulmonary mechanics reduce distensibility of the lung. Reduces compliance. Airway resistance increased. Some reflex VC. Some due to coughing. Reduces the radial traction effect of increasing lung volume. Surface tension pressure is determined by the law of Laplace, P equals 4T/R. Thus, pressure will fall as the radius of the sphere increases. Thus, a smaller sphere should empty into a larger sphere. Surface tension. Note that air inflation curve is right-shifted. Reduced compliance. Due to surface tension. Surfactant. Reduces surface tension. Produced by type 2 alveolar cells. Contains a phospholipid, diparmethylphosphatidylcholine, DPPC. May be important contributor to respiratory distress syndrome in newborns. Surface tension. Main points: water has very high surface tension. Placing detergent in water reduces surface tension. Lung extracts have variable surface tension. How/why does surfactant work? DPPC molecules are hydrophobic at one end and hydrophilic at the other, thus the individual molecules tend to repel each other, an effect that gets stronger as they get closer. Physiological advantages of surfactant. Low surface tension increases compliance. Stability of alveoli is improved. Remember the tendency of small bubbles to empty into larger ones. Surfactant reduces surface tension more in smaller bubbles. Keeps alveoli dry. Elevated surface tension tends to suck fluids out of the low-pressure caps. Other physiological changes with pulmonary embolism. Gas exchange. Reduced PO2. Atelectatic areas act as shunt. Pulmonary edema. Lung mechanics. Post-embolism areas receive no blood flow. Causes bronchoconstriction, Reason why X-ray showed no ventilation in the region distal to emboli, short-lived USU. Chapter 8, Pneumoconiosis or pneumono-ultramicroscopic silicovolcanoconiosis, black lung disease. Harry, 60 years old, retired coal miner. Sob. Fatigue. Productive cough. Started working in mines at 17. Sob started 12 years ago. Smoked 1 to 2 packs a day since 15. Harry physical exam only positive findings, chest slightly overinflated. Ronchi heard on auscultation. Investigations blood work normal. X-ray showed fine particulate matter in lungs. Slightly elevated lung volumes. Slight obstruction and flow limitation. Slight hypoxemia. Pathogenesis types of pollutants: carbon monoxide largest pollutant. Nitrogen oxides. Produced from burning of fossil fuels, like coal and oil, form smog. Sulfur oxides. Gases that come from burning sulfur-containing fuels, power stations. Hydrocarbons. Normally found in air, in combo with sunlight, can cause photochemical oxidants. Pathogenesis: particulate matter, wide variety of particles, soot. Power stations and industrial plants. Photochemical oxidants. Ozone, peroxynitrates. Formed from the action of sunlight on hydrocarbons and nitrogen oxides. Cigarette smoke. 4% CO. Nicotine. Hydrocarbons, tar, causes bronchial carcinoma. Deposition of aerosols in the lung. Aerosol, particles that remain airborne for a substantial period of time. Impaction. Largest particles fail to turn corners. Lodge in nasopharynx. Nose filters large particles well. 5 to 20 μ are almost completely filtered. Deposition of aerosols in the lung. Sedimentation. Gradual settling of particles because of their weight. Medium-sized particles. 1 to 5 μ, in small airways. Diffusion. Random movement of gases. Only in smallest particles, less than 0.1 μ. Many particles are exhaled, too small to sediment, too large to diffuse into blood. Clearance of deposited particles. Mucociliary clearance. Mucus, bronchial seromucous glands. Goblet cells. Film is 5 to 10 μ thick. Solid gel layer. Gel, superficial, viscous, traps deposited particles. Sol, less viscous, allows beating of cilia, clearance of deposited particles. Mucus contains IgA. Important in defense against foreign particles, bacteria and viruses. Cilia, 5 to 7 μ long, beat 1000 to 1500 times per minute. Propel gel layer forward. Moves at 1 mm to 2 cm per minute dependent upon the diameter of the airway. Eventually swallowed or gobbed up. Normal mucociliary clearance is impaired. Pollution. Toxic gases. Tobacco smoke. Alveolar macrophages. No mucociliary apparatus in alveoli macrophages. Engulf foreign particles via amoeboid motion. Phagocytose. These particles, kill through lysosomal activity. Can migrate to small airways and climb the mucociliary ladder. Leave blood in lymphatics, or blood. Activity of macrophages is impaired by cigarette smoke, ozone, hypoxia, radiation, corticosteroids and alcohol.